This is Dr. Matthew Bramlett, and this lecture is focused around hypoplastic left heart syndrome. And what we're going to discuss will be the anatomy of hypoplastic left heart syndrome, which we have 2D diagrams here. Here's a drawing of it, as well as the model. From there, we're going to discuss sort of the neonatal presentation of a patient presenting to, for example, the ER or clinic, undiagnosed or even in the nursery, and uh, what the clinical presentation looks like, as well as the impact of oxygen uh, and the role of the hyperoxia test in a diagnosis such as this, and understanding a little bit about the hyperoxia test and O2 dissociation curve and how we're moving oxygen around in the blood. So a good precursor to this lecture will be the oxygen in the blood lecture, which I've previously presented. Critical principle in that is going to be the Fick principle and how we get there from normal values, because that's going to be how we determine different QPQS shunting as relates to systemic and pulmonary uh, blood flow. So sit back and dive in. A couple things I always recommend everyone do. During this lecture, there are going to be moments. For example, I would say, okay, what I'm going to do next is I'm going to place an arrow on the primary structure for an aortic version of hypoplastic left heart syndrome, and I want you to do that first. So pause it. So what you will do is when I instruct you to pause it, will be to pause it and do what I just said, and then I will resume it. And when I resume it, I will, for example, say, here's aortic valve that aortic atresia caused this patient. The idea here is that you can preemptively attempt to perform the action of learning and then see sort of it witness the correct action moving forward. I'm going to do some of that with the oxygen saturations here. So while they look like speed limits in Europe, this is actually, these are representing the oxygen saturations similar to I have 75 here. So I've just put a bunch in so I can move them around on the diagram, which you'll see later. So good luck and move on to the next one right now. So for this section, we're going to discuss the anatomy of hypoplastic left heart syndrome. And so the first thing I'm going to draw your attention to here is probably fairly accurately sized small hypoplastic left heart syndrome. You can tell that there's only a single right ventricle. There's not two ventricles. But you'll notice here that there's a real small structure here. So let me go through the anatomy here on the chart. We have the SVC, IVC right atrium coming across the tricuspid valve into the normal or enlarged right ventricle out to the PA. We have the branch PAs, which are normal. We have a PDA connecting us into the aortic arch. Everything downstream from the aortic arch is normal. We have the left atrium here behind this oxygen saturation, and then we have an atretic either mitral valve or aortic valve. That means the mitral or aortic valve did not form, either one. As a result, and we have this moniker in sort of fetal development, no flow, no grow. So if I'm inhibiting flow either out of the LV or into the LV, this LV is not going to have the impetus to grow during fetal development. And so everything downstream of that, including the ascending aorta, does not develop. And so that tiny structure here, which is not uncommon for it to be 2 millimeters, is that little ascending aorta. So I'm going to blow this up so you can actually see it, but you might want to rewind it and just take a look at that from just a second ago. This is the ascending aorta. You can actually see on this model where the coronaries came off. So for the coronaries to fill and supply blood to the myocardium, it's coming up the MPA, which you can tell is dilated. And if you're standing right here where I am looking at this looks like an aortic arch. And in fetal development, it frequently can be mistaken for, and even a normal patient, an aortic arch, but this is the ductal arch. The ductus arteriosus is right here. Here is the LPA and the RPA over here, this direction. And so, this gives you a good sense of how much blood is actually flowing through the ductal arch, because all of it is. And it's actually coming back in retrograde filling. Here's for the arch is right here, the transverse arch, and this is the the most distal portion of the ascending aorta before the brachiocephalic artery comes off. And so all of the blood that's coming back from the lungs, which is a smaller percentage, obviously, during fetal life, because the placenta is supplying oxygen, has to get out of there. And so in the presence of a restricted atrial septum, that can have near fatal consequences at the time of delivery. If we diagnose that prenatally, we can be prepared to deal with it. In some instances, that can be the cause why it may be even fetal demise. But there has to be this egress of blood out of the left atrium during development. I have these representative saturations of, for example, a newborn. And what's occurring here is typically the SVC is going to be a little lower than the IVC, but most of the mixing is occurring here in the right atrium. If this number is different than all the downstream values, it's usually sampling error, like is represented here. But so mixing occurs in the right atrium. Everything is fully mixed by the time it gets to the right ventricle, out to the body through the PDA, which is represented down here. So what we're going to do next is we're going to run through the Fick equation. Before we do that, I want you to answer a few questions about the anatomy as represented here, and we'll go on from there. So now let's discuss the presentation of an infant in the newborn nursery with hypoplastic left heart syndrome. So first thing you're going to notice, they're probably going to be, a lot of them are chunky and look fairly healthy right out of the gate. And so, and dependent on this exam, they may not have a murmur, depending on some of the findings here. One of the things that we will notice is that the oxygen saturation in this infant is about 80%. And so whether or not they're cyanotic is dependent on the relationship between the saturation and the hemoglobin. If they're anemic, you're probably not going to have enough to see the blue. If they are plethoric, then you probably will. So a couple things. This is our Fick equation here. And so we reviewed this previously in the oxygen in the blood series, but what we're going to go through here is the simplified equation to get us to the relative flow to the lungs compared to the systemic circulation goes, you take the systemic saturation, which in this case is 80%, minus the mixed venous saturation, which is returning to the heart. And in most instances, a general rule of thumb is you get about a 20% or 20-point drop between systemic and mixed venous, and which is in sort of a loose indicator of uh, sort of oxygen consumption, how much blood is oxygen is being pulled out of the body. With poor cardiac output, that difference will increase. And so then you have the amount of blood going to the returning from the lungs minus that going to the lungs. So you have pulmonary venous minus pulmonary artery. So again, we have systemic minus mixed venous over pulmonary venous minus pulmonary arterial. And in this instance, you see 1-to-1. And what that means is we have one part going to the lungs, which is equal to one part going to the body. That's generally going to result in good peripheral pulses, and this baby's probably going to be looking fairly healthy. So now we're going to change the scenario here, and what I'm going to do is I'm going to put up the next scenario, which is this, and I want you to pause it, and what I'm going to do is I'm going to put these values where they go, and I want you to do the same. So pause it, and then when you return, check and see how you did. Okay, so mixed venous, 52. We have systemic saturation, and we have the pulmonary arterial saturation, which you can see here, systemic minus mixed venous over pulmonary venous minus pulmonary artery. Now, what does this kiddo look like? Well, he probably looks pretty good as well. He's going to probably be blue at this point, so you're going to notice that. But the amount of blood going to the lungs is, 0.6 compared to that that's going to the body. So this child, again, is going to have good peripheral pulses. And it's always important when you're checking pulses, if you can feel a good radial or pedal pulse, then you know that you've got good perfusion because you're not going straight for a central artery. But also of importance is you always want to feel a foot pulse. That's if I can feel one pulse on a kid, it's always that because there is a PDA here that is at risk for closing. All right, I've got one more scenario for you. I want the same thing to occur where I want you to select, put all these up here, and then we'll resume. Okay, here's mixed venous. We have systemic and PA. In this scenario, excuse me, this kiddo is probably not doing too well. Why is he 90%? That's because you came in and you put oxygen on the baby that was blue. You took one of these kiddos here that was doing just fine, and now, while your saturation is better, what you can see here is we're extracting more blood because we're 2.8 to 1. That means the lungs are filled with 2.81 the amount of blood that's going to the body. He's having to breathe hard. His heart's having to pump all that extra time to get to the one systemic circulation. All right, some questions next. Now we're going to discuss the hyperoxia test. So, first of all, the indications include a saturation of less than 90%. In this scenario, we have 80%. PA, and so if you have a newborn infant with SATs that are less than 90%, that'd be a good indication, as well as a few other things. But it's essentially, if your PaO2 is greater than 200, it's going to rarely be cyanotic. If your PaO2 is less than 70 in the presence of a normal PCO2, then congenital heart disease is very likely due to the mixing. An infant, so if you have an infant between 150 and 200, congenital heart disease is unlikely, but you certainly need to investigate further. And so what's occurring with the hyperoxia test? Well, in a normal scenario, you're gonna breathe in your oxygen. You're gonna get it in alveoli to about 100 millimeter mercury pressure here, and it's going to extract oxygen, and you're gonna get about 30 coming back. So 30 coming in, it should all go up to 100. You should be able to check 100 on room air. But what occurs because of mixing, and so mixing is occurring where we have 99% here, and in this chamber there's complete mixing. And so the whole purpose of this is no matter how much, whatever the PaO2 I can generate here is not going to get to a point where I can get very high. In most cases, above 7, I won't be able to achieve greater than 70. And so here in this scenario, we've given 100% oxygen. So how can you give 100% oxygen to an infant? Well, you can use an O2 hood, where you essentially just envelop the whole baby in a bubble of oxygen, or on a ventilator, you can achieve that. And so, in some instances where we do have these infants who are their heart is just pumping faster than they can manage, and their lungs have a lot of pulmonary edema, maybe from a slight restriction here, it's not uncommon to find some of these, in fact, many of these infants intubated. And so now into the alveoli, which is represented here, we have 600 millimeter mercury O2 pressure. And so we take our 30, we get to 600, but because we're mixing so much of this blue blood in, we're not able to get up to a high level. And so I failed to mention, whenever you're giving the hyperoxia test, you have to give the oxygen for 10 minutes before you repeat the arterial blood gas. So a couple things of importance. If we go back to our O2 dissociation curve and we consider this curve and its related relationship to PaO2 and hemoglobin, so that we have, these numbers are hard to read, so I'll help 10, 30, 50, 70, 90, 100 of O2 hemoglobin that is saturated. In this scenario, this is the PO2, and we have 20, 40, 60, 80, 100. Again, at the alveoli, we have 100, and resting, we have 40, kind of represented here by the amount of what's the PO2 of venous blood as it comes back here. And so, again, fetal hemoglobin shifts it to the left. So if I have an presenting oxygen saturation of 80%, my PO2, is going to be right in this range of 40%, which, tracks fairly well. If I give oxygen, let's say I get the saturation all the way up to around, right here, and I've got enough fetal hemoglobin at 95%, I'm staring down at a PO2 of 70, or actually, this would be like 96, or this would be greater, 94, 95, I might be able to hit 60 here. And so, you can't rely on what your oxygen saturation is to determine whether or not you have a positive or negative test. And from here, what we're going to discuss is different disease states and their surgical repairs. I will briefly sort of give you a preview of that. To repair this, I have to have it so when the heart squeezes, an appropriate amount of blood goes to the lungs, because I'm not using prostaglandins to keep this open. And so I'm going to use either a BT shunt or a Sano, and I'm going to connect the ascending aorta to that PA to give it enough bulk for systemic circulation. All right, thanks a lot. This is it. One more question.